Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to Let's Talk. I am Dr. Anita Raja. And today, once again, we are going to be discussing a very interesting topic. Most of us know at least one person around us who has resorted to a cosmetic procedure, whether that is surgical or non-surgical. It's becoming very, very common. But the question is, do we actually know what we are in for? Is the procedure of consenting the patient robust enough? To discuss this and much more, we have invited to our show Dr. Asalet. Welcome, Dr. Asalet.
Hello, thank you so much for having me on the show. Really excited to get started.
Lovely. So my first question is around the news that we had recently, and there was a lot on social media around the supermodel Linda Evangelista and a procedure that she had, which wasn't very invasive. It wasn't surgical, it was cool sculpting. However, she was left disfigured and she had mental health issues after that. And that is when the procedure of consenting came in front of us. And this was a question that was being raised. Do people actually know what they're in for before they go and agree to getting a procedure? What are your thoughts on this?
I mean, this case highlighted obviously a very significant issue about consent, especially in the UK. I mean, this was in America, but in the UK, as we know, there's less regulation compared to everywhere else within the private sector for cosmetic treatments or aesthetic treatments, essentially. So that's another issue that we'll talk about. But with her case, I think it's basically cool sculpting has been around for, at least 10 years. And it's a well-known side effect that can happen from treatment. Really rare, but it can happen. We don't know the full situation around her, obviously, how she was consented. It's all from her word of mouth as to what's happened, but it is an expected complication that can happen. And basically what's happened is that she underwent a procedure to reduce the fat within the area that she had treated, which is done kind of non-invasively with a machine that's called cool sculpting. But what it does is it freezes the fat essentially, and your body takes it away, breaks it down. With the treatment she's had, unfortunately, she suffered a consequence of that, which is a known complication where basically she had excess fat accumulation in the area that she treated, which is really unfortunate because obviously she's had treatment done to reduce this for her cosmetically and aesthetically, but it can happen. So it goes into other issues, I think, with consent. When we consent patients for anything, it does always make me think, within the NHS, but also outside of the NHS in the private sector, how much are the patients really understanding? So the key part of this, especially during, theatre operations that we do, surgical operations that we do, is you have the clinic time beforehand with the patient to go through their treatment options. On the day of the surgery, yes, we do consent them. Unless it's an emergency, you don't consent them on the day. You make sure that you consent them beforehand. You go through, give them time to think about it. Generally we divide it between common complications that are basically will happen with any surgery. You have bleeding, pain, risk of infection, and then it's also divided into procedure specific. And then it's also then divided into, whatever anesthetic is used, whether it's general anesthetic or local anesthetic, regional anesthetic, depending on all of that. Now, what I found entering kind of aesthetic cosmetic world is that sadly, this isn't done so well, especially in the UK. And I think this is a big issue because patients generally, they can go to anybody, on the street without a medical background who, I don't know, could be in a salon somewhere, trained in, it could be anyone. Basically, you could be a plumber and you can inject. That's how bad the regulations are. So the product they inject could be anything. We don't know what it is. They claim it's dermal fillers or hyaluronic acid, but it could be anything. So with that practice, consent is so much more wide compared to elsewhere in the world. We get training as, any medical professional, and so well, is that we get trained to go through that process with patients, and that's the end game to get to the consent. That before that, you've got all the groundwork of, the consultation, building a rapport with the patient, understanding their exact concerns, what do they want to achieve from the treatment, and then actually the advice you give would be tailored around that. That's the way I generally approach cosmetic treatments as well, because it's so important, I think, with my NHS background and surgical background, to take that forward and put it into my aesthetic practice as well. You need to make sure that we don't bring up other problems for the patient. So, for example, if a patient comes in and their concerns mainly are wrinkles, but then you start to talk about other areas of their face that you could treat, picking up faults, essentially looking at patients and analysing their face and saying, this is what we can do for you. I think you have to be really careful with the approach you take, because you don't want to turn this into an opportunistic thing, where you're creating problems for the patient when they weren't actually even aware of any of that. So there's a lot of ethics behind it as well. And I think that's why consent is multifactorial. All of this, when you put it together, it's really difficult to know that there is a consistency in the consent process outside of the NHS. But obviously this woman, Linda, she's from America, and her experiences is just based on what she's telling us. It's a known complication. But it does raise the question that patients need to be more careful who they go to, research their background, and make sure that they take time and they don't just go into someone's office or salon and just have treatment literally on the day without talking about much, just going in for a specific treatment and then getting it done. Patients don't dictate what treatment they want when they come to see me. I still take them through, even if they come in for lip fillers, I still take them through that process. I say, I understand your concerns. You want lip fillers. Can you tell me why? What are your concerns? What are you looking for? And I think that's so important, because actually it might not be that they need lip fillers. They need something else done. Or I've had people that I've just gone through kind of like a mental health assessment because they've revealed things to me that they haven't revealed to anyone else. So it's so important to take that medical approach and go through all of that, which I think is so tough, because even if you do it correct, you can still have patients at the end who might be dissatisfied for whatever reason, or have complications and still feel like they, weren't prepared enough for that. So it's a lot of covered that.
And I agree, but it makes it very difficult. It makes it very difficult, especially in an era where we are certainly desperate. I mean, if you look at surveys around us, if you look at the Girls Guide survey, which was conducted a couple of years ago, about how women felt about themselves, it was shocking. 2/3 of girls between the age of 11 and 21 were actually not happy by the way they looked. And 1/4 of them actually were thinking that when they grow older, they would definitely get a cosmetic procedure done. And I guess when someone comes up and says, look, I'm going to do your filler for half the price, then it is a degree of desperation, because it sounds like such an amazing deal.
Definitely. And I think that's it. You've put you hit the nail on the head. It's about marketing, advertising. And because there's lack of regulations, obviously, around the area, again, I've had patients who've come to me with deformity produced from treatments like that, where they've had injected cheek fillers, for example, just as one example, and one side is massively bigger than the other. And she thought she went to a nurse. That's what the person claimed they had. We looked it up in the register together. That person wasn't on there. So there is a lot of false advertising from people claiming that they are lip masters, lip doctors, giving that impression to patients that they're qualified and they're, trained from Harley Street, trained and qualified. But in what? They don't substantiate that. And sadly, because social media and the way everything works, patients generally will refer to that and see that as like a review and look at the number of followers. People can buy followers, so many things that happen. And people do seek treatments from people that they think is actually genuine. And this coupled with everything that social media does, and the fact that women are made to be seen as, you have to be beautiful, you have to be successful. you have to basically balance and be best at everything. So it puts a lot of pressure on women, and then they turn to social media. Social media, again, you've got gorgeous, beautiful, successful women, have kids, bounce back, no stretch marks, photoshopped. So when they see all of this, they think this is what is normal. They think that's what's normal. Or even skin. We have a lot of people coming to see us, for skin issues, and it's normal to have pores. You can't get rid of your pores completely. In real life, we all have pores, but they don't see that on Instagram or, Facebook or other networks. So it's really, again, it's so important to take the time to, I think as clinicians, we have a duty of care. And I think using that consultation to try to bring that patient back in and set what's normal. And actually, it's really important, again, if you realize that there is a sense that there's no normality and you're thinking of body dysmorphic syndrome, that you take the time to assess and not treat the patient on the same day. So it is really concerning, because everyone wants to feel beautiful. Everyone wants to be able to, I guess, live a happy life, and happiness is defined by what we see. And we see a lot on social media and a lot of things that are dictated to us. But again, it needs to be done in a safe, correct manner that's not excessive, conservative. And I think that's really important overall.
It definitely is. It definitely is. And when we think of cosmetic procedures, unfortunately, there's this unrealistic expectation that you want to look like somebody. And one thing that I've certainly heard from doctors around me, friends like yourself who do cosmetic procedures, is that a patient will come through and say, look, I want to have lips like this model, or I want to look like that person. And there is a lack of insight into understanding that you are from a different ethnicity, you look in a different way. I mean, you belong to a completely different culture, genetic pool. How can you possibly look like someone who lives in a different part of the world? It's a very interesting topic that we're discussing today, viewers. If you want to be part of our show, it is very easy. Our number is on your screen, 019-242-31083. You can also WhatsApp us on 0758583550. We're talking about consent and aesthetic procedures. It's time for a break, but stay with us. Welcome back to Let's Talk. Before we went on to the break, we were talking about consent and aesthetic procedures. And it is ironic, actually, because when we look at the UK and the regulations here in the United Kingdom, then female genital mutilation has been banned. Yet, if we look at the labioplasty industry, it is booming. Why is this happening? I'm going to ask this very important question from our very lovely guest, Dr. Asalet, who's here with us in the studios. Dr. Asalet, thank you so much for being part of the show. So my question is, why are so many women conscious about tidying themselves up?
I think it goes on to what we've been discussing before about body image and negative body image and what we see again on social media. But social media aside, one of the biggest industries is pornography. It's unspoken, but it's in our lives everywhere, and it's a lot of what people are exposed to. It might not be direct exposure. It could be based on what the partner might mention or say. Somewhere down the line, women think what they have is abnormal, which is triggered by different aspects. So it comes in all shapes and forms. It's normal for women to come in many different sizes and shapes. But because labioplasty, so labioplasty, we should probably explain what that is, but it's basically a surgical procedure to excise and make the labia minora, which is the inner part of the lips, smaller for women. They're private parts, basically. It's so normal to have different shapes and sizes of this. People might have a bigger labia majora, which is the outer part. They could have a bigger labia minora, and it's so normal to have different shapes. But because of what is seen on pornography and areas where basically you can see women exposed, who have probably had a lot of these procedures done, it's seen as quite normal to have this. A lot of the women from these industries have a lot of cosmetic procedures, from breast augmentation, labioplasty, liposuction, to name a few, on top of the non-surgical elements such as fillers and Botox, best lighting used within cameras, and all of this. But this is what people see, and they think it's normal, and it's a negative body image, generally, that people see. You know, having a baby changes your body. Just being in naturally a different shape in general. None of us are the same. We're all unique in our own different way. But sadly, because of all of this that is out there, and it's become an epidemic, I think, and it's getting worse and worse, which is quite worrying, because anyone who has, you know, sisters, young.
Yes. So Dr. Asalet was explaining how this is a very tricky situation, because around us, if we have any of our female relatives, friends who are actually suffering from the worry that they might not look normal because they've got this certain expectation. Because as Dr. Asalet, you were saying that, you know, it's not just the perception of the person. It is worrying, because we've got so many women around us who could be worrying about how they look down below. But the biggest worry is, in a country where we're saying female genital mutilation is wrong, how is labioplasty right? How are we allowing that to happen? Why are we not telling people that, you know, this is absolutely normal? Why are we not reassuring them? And does that not automatically put the responsibility on our shoulders as clinicians?
You're right. And I think it all comes down to financial incentives, doesn't it? It's a private industry, cosmetics itself, and financial incentives, of course, but also it's the wording, isn't it? When we say female genital mutilation, it goes into the case of religious aspects. Whereas if people are having labioplasty, generally they seem to accept a bit more, because it's a bit more kind of like a Western issue. And I think this is me just being blunt and putting it out there. And I think that's the main driving factor. It's just changing the terms. But equally, it is quite similar, isn't it, when you think about it, that we're changing down below for somebody else's benefit.
Exactly. And also it makes it more worrying, because you're changing yourself down below for someone else. And also, in general practice, one thing we see quite a lot is that mums bring their daughters in because they're worried about how they look down below, or how it may affect them in their future lives. I mean, this is certainly something that we need to discourage, I guess. I mean, how can we get back to normal? You know, when I was much younger, I mean, and that was not very long ago, things were so much more simpler. And now everything is just so complicated.
I think so. I think it's definitely something that I always reflect myself. And I think I'm guilty of it, even though I'm within this industry. I do it sometimes, you know, I do the same thing, thinking, have a negative self-talk to myself. And I think being aware, raising awareness, which is what we're doing right now. We're talking about it, having an open culture, and even between family members or anyone that you engage with conversation, actually just being quite open and opening this discussion up to say it's normal. You don't have to mention the graphic side of things. You could just say it's normal. We're all shaped differently. You know, and that's fine. And I think it starts off when they're really young as well. So, you know, little children when they're toddlers, and we quite do it subconsciously, but I think a lot of parents do this, is, you know, if your daughter or son or whatever has curly hair and you prefer straight hair, you might end up imposing this on your child, or just by mimicking the actions that you're doing. If you're straightening your hair, and they notice, and I'm giving this example because of my daughter, mainly, because I was straightening my hair and I hadn't realized that, you know, she was seeing this, and she's got beautiful gold, kind of, you know, blonde locks. And she started to say, straighten my hair, as if having curly is a bad thing, you know, curly hair. And that's where it made me think, oh my gosh, what am I teaching her? You know, I should be you know, educated. I thought I knew a lot about this, but even I'm doing things to encourage her and make her think that it's a bad thing. And I think it's just having that mindset and trying to be aware. And I think being open and trying to engage in conversation. And as clinicians, for us, any engagement you have with your patients, I always use it as an opportunity. And I think a lot of my colleagues that I know really well equally do the same. is use that as an opportunity to talk about things. If they want lip fillers, why? What is your concerns? Why don't you like the shape? What don't you like about the shape? A lot of the times, actually, they have beautiful shape to begin with. So, and it's a lot of those things. I think it's just engaging in that conversation of what we can do and what is normal to do, not changing. Another thing is, I think a lot of the time, so we talked about labioplasty, but a lot of what we see is the external kind of cosmetic treatments that people have. So it could be excessively augmented breasts, to excessive amounts of filler in the cheeks where patients are quite puffed up. If filler is done normally, in a kind of conservative measure, then actually it could be so natural and make patients look like they haven't had anything done. Restored anatomy, if it's due to aging, if it's congenital reasons, if someone's got really kind of retroganthiad, small chin, you could add either chin filler or chin implants to try and bring it forward. And that's going to help them with their bite, how their lips sit. So it's just looking at the whole anatomy. Similar to breast augmentations, which is another area I think that's definitely grown. And I know you want to say a few things about that as well. But again, it's an area which is massively grown, and I think done naturally to suit the shape of the patient. If there is, bulbous, so there's lots of different types of problems that patients can have, which we can say, maybe breast augmentation is the right thing for them. But a lot of the time it's done due to cosmetic, that kind of extrinsic factors leading them to kind of make that decision rather than it's something that they actually feel they need or want, I think.
Definitely. Exactly. And if we look at the numbers, so this is one thing I wanted to share with my viewers. According to the British Association of Aesthetic Plastic Surgeons, there was a survey that was conducted, and in 2002, 2003, around 10,700 breast augmentations were done. So that was the most widely done procedure, still is, in the UK. And when we look 10 years down the line, that's gone up to 50,000 procedures. Now, the difficulty is that you can get these procedures done much cheaper abroad, and many people will actually go abroad, get them done. However, if they've got complications, again, consenting is the issue here. The procedure has been done, it's been done abroad, but now they've got a problem. The implant has burst, for instance. Then they need to come to a clinician within the NHS, asking them to help them out, which becomes very difficult. Do you want to shed some light onto this very, very sensitive issue?
Oh, goodness me, yes. Which part to answer first? So the bit that you mentioned at the end where, patients come back and they have complications from abroad, we see that so commonly within plastics, from really deep-seated infections where they could have breast augmentation and a tummy tuck and then have so much whatever complication they've had to lead them to an infection, probably not good technique within the operation, leading to them to have an infection. But when an infection is at that level, it's very hard to treat. It might be that the implants need to be removed, that they need long-term, what we call kind of negative pressure wound dressings, which will leave the wound open and have to go back to theatre a couple of times and have lots more tissue removed, then having a skin graft over that area. So many issues, and this will all be for the NHS to sadly pay, because they cannot leave the patient unsupported. Yes, they made a silly decision, but this is the NHS, isn't it? They look after everyone. So it's really sad. It's cheaper. It's much more lucrative for people to go because it's easily accessible. It's sold like a holiday package. They can get their teeth done, their breasts done, labioplasty, a whole package. So they tend to opt for this. Sadly, if things go wrong, you haven't got anyone to look after you. And that's the key concern. I think you need to think of, when you're doing something, you have to think of your whole patient journey. From the time you get consented to the whole follow-up and after the procedure, you need to have that person available, accessible, in the same country so you can see them. Because if you get unwell enough and you have an infection and they're abroad, you're not going to get on a plane to go see them, 10 hours away. That's not realistic. You won't even get insurance to be able to fly and go there.
Lovely. No, Dr. Asalet, you're absolutely right. It was such a pleasure to have you on our show today. Thank you so, so much for taking out your time. I could have talked to you for hours on end because it's such a beautiful conversation that we were having. Viewers, we were talking about consent in aesthetic procedures, and it is a very, very sensitive topic. At the moment, you've got our number on your screen, so we're going to continue this conversation, but after this break. Welcome back to Let's Talk. I am Dr. Anita Raja. Before we went on to the break, we were talking about consent and the procedure of consent in terms of aesthetic procedures. However, this topic doesn't end here. It's a very vast topic, and I'm very passionate about it because it's something that we see quite frequently within our society at present. I mean, we live in a free world. United Kingdom is a free country. You can do whatever you like, but the question arises when things become very cheap and accessible, procedures become accessible, and then there is a new standard that is set, and everybody else around these people who get different procedures are obliged to get procedures as well, because that is the new norm. Is that good? Is that bad? This is going to be the second half of our show today. We have invited Dr. Thuva, who's an aesthetic surgeon, and he's going to speak to us about his experience. So welcome to our show.
Thank you very much. Pleasant to be here.
Dr. Thuva, the first question I wanted to ask you was that it was quite striking, astounding actually, when I looked at some numbers. And it seemed that if we look at South Korea, for instance, 60% of women in their late 20s have had a cosmetic procedure, and around 40% of women in their early 20s have had a cosmetic procedure. So essentially, most of the people you see around you in South Korea have had a procedure done. What do you have to say about this sort of new norm that is being set?
I'm not surprised, to be honest. We've always known that South Korea, most of our products actually, that even some of the products we use in the UK come from South Korea, and a lot of innovation in the industry happens in South Korea, so I'm not surprised at all. And if you look at the direction of travel, from when we started training in many years ago, you know, the industry is growing at a catapulting rate thanks to people like Kylie Jenner, who've set a trend, and of course the reality shows, you know, Love Island, etc., are only making it more normalized. However, I do still think there's still a stigma attached to it in our communities, especially the, you know, South Asian and Asian communities. So I think there is still some room to go there. However, I do think, you know, there is a right patient and the right situation for treatments like this, and there are certain settings, certain places where they may not be the right thing or not be done by the right people. So we do have to take the full picture into account when we look at whether it is good.
Right. But Dr. Thuva, then why is it that 85% of people who actually get a cosmetic procedure, whether it's surgical or non-surgical, are women? Why is that?
That's a very interesting question posed to a man. I have to be very careful how I answer this, don't I? I guess a lot of the role models and the people portrayed in the media who have such procedures are women. Therefore, women look up to them, appear to be more appealed or tend to want to have those things done in order to, enhance their beauty. I'm just generalizing here. Women do look after themselves better than men. We are terrible at looking after ourselves, both in our health and, in our skin and how we look. In the Asian communities, women do play a bigger role in looking after their other half and their sons and parents, husbands, etc. So I think that has a significant role to play in why women are doing this more often. And I think the other thing is women are more comfortable with this and they have a better pain threshold. I think that's something we miss. Especially when I treat patients, I notice that difference. Women can go through and take a lot of pain compared to men. And I know I'm going to get shot for saying that. But
I'm going to take that as a compliment, definitely, because because it's not very common for a man to appreciate how resilient a woman can be and how strong a woman can be. So that's certainly a compliment that I am going to take. So Dr. Thuva, how many times have you actually, because you are within this industry, you're part of it. So how many times has a woman actually come to you or a man has come to you asking for a procedure that you've actually declined and turned them away with because you thought that that is not in their best interest?
That happens quite frequently, actually. In my practice and when I'm training as well. Some of the times you have patients who've had lots of fillers done elsewhere that come to you because they want more doing, because either they've been turned away by their own practitioner because they've seen that they're going down the slippery slope of BDD, that's body dysmorphic disorder, where one starts to criticize their own appearance and become so focused on it that it's a detriment to their own health and their mental well-being. That's one element of it. The other is, you see the pictures in the Daily Mail now of people who have so much filler in their cheeks that you're distorting natural beauty. And again, I guess the eye is the beauty in the eye of the beholder. So there are certain lines where you can cross, but it's the ultimate responsibility for the patient's well-being, not just in terms of the aesthetic appearance, but also in terms of the mental health, lies with the practitioner. So I do come across a lot of patients where I do suggest that one thing may not be the appropriate thing, but there may be something else where we can focus on, etc. So there are ways to handle this, and the ways, and I do think we have the ultimate responsibility, and I think we should abide by that.
Okay.
Never mind patients.
Definitely. And I think it puts a lot of it puts a lot of responsibility, and I think a moral responsibility on the shoulders of the clinician who's actually looking after these patients. Now, you did mention that you drew this comparison between men and women. So I am assuming that you get quite a few men come in for procedures as well. What sort of procedures do men want? I mean, what are they looking at enhancing?
So men tend to go for either the upper face Botox, where they've got dynamic lines, they want to resolve them, or static lines where they're trying to recover from, or things like liquid nose job, rhinoplasties with fillers. That's a common thing, because as much as the aesthetic industry is to optimize and enhance beauty, there are things that we do in the aesthetic industry that also help people deal with things that really, really bother them in terms of their psyche. People have been criticized for the appearance of their nose, and so that that takes a big knock on someone's confidence, and so that can really turn someone around. And there are other things like, I've treated patients with trauma to their lips where they've had a dog bite them and they've got complete asymmetry, where you can correct that really and would get really good results with fillers. So it's not a pure enhancement effect. It can also help someone's mental well-being by helping them build their confidence, and it really does go a long way in the right patient.
Right. And in terms of disfigurement, this is a very interesting topic that you've actually just raised here. Do you think that the NHS should actually help in correcting disfigurement, and maybe these cosmetics procedures or aesthetic procedures should be subsidized for people, because it may well encourage them to go to the right people like yourself, like Dr. Asalet, rather than people who are sitting in a beauty salon, have no sort of medical background, and are actually carrying out these procedures?
You raise a very interesting point there. I just like to draw and reflect on my other roles and things. We have to look at where we are in terms of the NHS today. We know how much of a struggle it is for GPs to uphold what is basic healthcare need, and to meet that demand is hard. So given that context, I would find it hard to argue for this. But it's a very good point that you make. If we were in another situation where we had enough resources and this was an opportunity we could explore, I would definitely say so. But in this current climate, I would find it hard to argue for this over the other crucial healthcare needs that are still we're struggling to meet on a day-by-day basis. On the other point about beauticians, you raised about, again, a valid point. you do have to value your health in some ways, and in some cases, I guess we have the duty to educate patients appropriately.
Yeah.
And I think we could definitely be doing a better job in terms of public health and making patients aware. This is an implant that's going into your face. It's not to be taken lightly. There are significant things that can go wrong with these things. So that's where I think normalization of these procedures, maybe we need to take a step back on that. But it's doing it the right way. So I think it's something to think about.
Right. But Dr. Thuva, are we emphasizing enough on things that may go wrong? Or are we encouraging patients when they come in by promising them that we will be able to correct the disfigurement, for instance, we will be able to get over that scar that they've got on their face due to the dog bite? Is it something that we are doing at the moment?
So when it comes to me, and we know, I think you've already talked about the consenting procedure. We consent extensively for every single patient. That is not common practice. You know how hard it is as a doctor yourself. Consenting is a very tricky thing to get around. It's not that straightforward. And especially the recent Montgomery ruling, where it says you need to inform the patient of what is important to them, not what you feel is important because of how common it is. Some of the things we talk about when it comes to fillers, for example, blindness is a possibility with fillers. It must be mentioned in the consultation. I would beg to differ how many practitioners out there, even some clinically trained, mention that in their consultations. So it is a frightening thought, and I do think we could definitely do a better job at doing that.
Definitely. And it was quite interesting how you mentioned the Kylie lips initially when we started this conversation. How many times have you actually been able to tell your patients that there's a lot of airbrush behind this, a lot of filters, and that this actually might not look like it seems?
Sure. Me and a couple of my fellow trainers, we always get or make this joke that patients come into clinic with someone on Instagram or a photo, and they put it out and they say, "This is what I look like." And I think it's part of your job and demonstrating how good you are in being able to set patient expectations right. As we know, if you under promise and overdo your work, then the patient is more likely to appreciate your work. And with a business hat on, that also brings you more referrals futuristically. It's going to help you grow. So that there's two elements to that. So I do think that's important that you set the expectations right. We can do a lot for a lot of conditions that that's not available on the NHS. But it's small steps, and it sometimes requires a combination treatment. However, we're not going to knock back, 20, 30 years in most cases. We can do what we can do, and having a portfolio is always helpful, so you can demonstrate the extent of the results, so that patient expectations are realistic. But yeah, that is a common thing. People turn up with photos and this is what I want to look like. I'm not sure even a knife can do that. Sorry.
No, that's absolutely right, Dr. Thuva. Dr. Thuva, you're absolutely right. I mean, it's very important that we have realistic expectations. It is time for a break. You can be part of our show. Our number is on your screen. Stay with us. Welcome back to Let's Talk. Before we went on to the break, we were having a very interesting conversation with Dr. Thuva around cosmetic procedures, the expectation that the patients have, and the unrealistic expectations that some women and men have in terms of looking similar to celebrities that they see on social media. Dr. Thuva, thank you so much for being on our show. I thank you once again. And before we went on to the show, you were talking about how important it is for a clinician to set a realistic expectation in terms of different procedures and be very honest with their patients that, look, this is not something that we can achieve, this is not in your best interest. However, there is a very big factor out there, and it is the disability factor. Now, the norm has become super good, and hence there is a worry that people who actually suffer from disabilities like disfigurements that you've mentioned are now under immense pressure to correct those. What do you have to say about this rising concern?
You're absolutely right. I think so the media and these reality shows are setting extreme expectations of society, and especially the youngsters, even from teenage, things, there's a distortion of what is normal, and that's a real sad thing to see, because those have a psychological impact, not just on us adults, but the kids when they're growing up, and it shapes you, how you behave, and what you expect from life and things. And it takes a big toll. In terms of how that's affecting people, I guess the way I see it is most patients come to my clinic because they want something doing, because they are bothered by something. I never, there's a thing about hard selling. That's not something that should be done at all. When I train all my other fellow clinicians, when I do cosmetic, that's a no-go area. What you're here to do is help the patient in what they want help with. If they're so bothered by it, it's your job to help them offer what options there are. But what I always say to my patients is, this is optional. This is if it bothers you. Yeah, this is not mandatory. This is not impairing your health. But if it is, bothering you and you want to consider these are our options. I think that's the right way to do it, because none of this is necessity. Yeah, I can understand that. Yeah, I can understand. It may be perceived as a necessity of some of those people who've had such a knock in their confidence. They've grown up with a disfigurement, and they now can either afford to do it or are able to consent to have something done and have the access to it. So you have to factor that into account. I don't think it's an absolute. I think it's a case by case, and I think the patient must still remain at the heart of that discussion. It's up to the patient whether they want this to be done. My job is only to educate them on what can be done, and it's for them to then decide, is the risk and complications and how long it's going to last for, the cost of it worth having this, or trying this.
Definitely. And also, in terms of South Asian patients that you get, what is the biggest request that comes forward or you have seen within your practice?
Yeah, that's an interesting story. The biggest thing we see in South Asian women, in dermatology and cosmetics, is melasma and pigmentation. That's the biggest concern. And I know there are some, deep-rooted reasons for why this is such a problem or such importance to our community. Back home there is a distorted view that having paler skin gives you some superiority. So that, I think, is a historical thing that we're still tackling today. That has not been tackled completely. So that's one part of that question, I think. The second part of that question, I think, is that, unfortunately, people of colour, we're more prone to pigmentary disorders because of our ability to produce melanin more so than someone of Caucasian descent. So if we have such a simple thing as acne, we're more likely to scar. However, do we, as general practitioners in the UK, consider that when we look at a patient of colour? We don't. I think we treat everyone equally, as as a free society tells you to. But I think in this case, we have to treat people differently, because a person of colour is going to scar, and that's going to leave a long-term impact on that person, whereas a certain person, who may be of type 1 skin isn't going to scar or will recover better. So in my practice, in my dermatology practice, I escalate very quickly in my treatment plan in order to avoid that happening. So that's the NHS impact of it. And the other thing I do have to say is we know that clinical practice, even in the modern world, isn't just does discriminate. One of the things that we know discrimination can be a factor is we've seen it during the COVID, vitamin D deficiency. We're more prone to vitamin D deficiency because of our skin tone. Equally, we're more prone to melasma because of our skin tone. And there are lots of women out there who have melasma and are very worried or conscious of that fact. But there is nothing on the NHS for it. Nothing at all. Yeah, we used to offer pigment in some places with pigment condition. The CCGs are cutting the funding for it, because I can understand, there are other pressures elsewhere, but it's such a prevailing condition. How can we just say there's nothing to it? So those are the sort of women I see in my practice, coming with melasma. That's where I think I can ethically say there is a reason for me to help you try to lighten that pigment, because it's the condition that I'm trying to help you. And equally with acne scarring and things like that, you have to be a bit more careful with skin color in terms of how we treat it, because of its risks with all cosmetic procedures in terms of its refractory scarring possibility. So we have to prepare the skin in order to limit the possibility of pigmentation. And equally when it's treatment, you have to just be gentle as to how you escalate the treatment pathway. So that's my experience of practice.
And Dr. Thuva, you rightly highlighted the fact that there's a lot of discrimination in terms of people of color. I mean, if you look at our medical books, for instance, I mean, you're a general practitioner, I'm a general practitioner, and certainly when we were studying dermatology, I don't remember a single picture of a lesion on a skin which is a skin of color. It is something that I am seeing more widely now, and I'm really pleased about it because people have raised this question. Yes, this rash looks a certain way on white color, but what about people who've got brown skin? What about people who've got black skin? How does this rash look on them? Which makes it very difficult for us, I guess, as clinicians to identify different rashes and conditions in people of color. Another thing that we see quite often in general practice, and I would like to ask you about your practice as well, is hirsutism, a condition where people of color, people from the South Asian community, for instance, are at a higher risk of having more hair on their face, facial hair, than their whiter counterparts, because I guess the white counterparts may have hair on their face, but it's blonde, which is so much easier to hide. However, if you look at the NHS and funding on the NHS, unfortunately, the treatment is not for free. Do you get many patients who come to you with this complaint?
Yeah, that's a very interesting question you raise, and a very valid one. Hirsutism, it's very easy to blend on pale skin, whereas impossible or much harder on colored skin. We do see a lot of patients with that come through to our NHS and private service. We're based on Soho Road, so you can see we see a lot of skin of color women come through, and they have laser hair removal with us. So that is a very common complaint.
And in terms of encouraging people, making them feel more confident about themselves, what sort of strategies do you think we as clinicians need to devise? Because it is quite sad when you see people around you who are so dissatisfied by the way they look.
You're right. I guess we're going into the territory of mental well-being, healthy living in that context. I think if they felt that they were satisfied in other aspects of life, that's a simple strategy to make them feel happier and better, and that might in itself have a knock-on effect on their confidence, on how their appearance is. Because we all know, if you're feeling good, everything else looks and feels good. If you're feeling sad, then every small thing that happens is blown out of proportion. So that's a simple thing, I guess. Good diet, good exercise, and a good job, if you can, where you're not stressed, and a good home life can help. In terms of your look, I guess what you can do to make yourself feel better is do incremental changes to your routine so that you feel like you're doing something about it. That might help. Making sure you're cleansing your face twice a day, simple things like that with a good cleanser, and just moisturizing, wearing sun protection every day. It feels like you're empowered, then you feel like you're doing something about it, and then you will see some subtle changes that will make you feel good, and hopefully that will perpetuate, and you might end up with a better result as well.
No, definitely. You're absolutely right about it. We're only left with 2 minutes. In the end, we're just left with 2 minutes. In the end, is there any message that you want to give people out there who are watching your show today?
Sure. Yeah. So the message I want to give is, I think personally, there's still a stigma around Botox, aesthetics, cosmetics in our South Asian communities. I think we need to go away from it, and I think we need to unpick that, and you need to normalize that. We need to understand, where the need is and what we're used to from the ancient media portrayal of Botox and fillers, where it's extreme results and extreme things, which still happens today. So I think it's our job to educate those patients and the community on that. And I do think there is a there's a big opportunity for us to help, again, women with such conditions as melasma and pigmentation, and for us to educate our population and our communities on the need for them to seek their appropriate help early on with their skin disorders, so that they prevent, post-inflammatory hyperpigmentation, which is, prevalent in our community. At that point, there's nothing the NHS can do. But I do want to highlight we have to be conscious and work with our GPs. You know, they're under immense pressure, so you have to reach the help and be patient and get the help you need as early as possible. And there is plenty of help out there, and make sure you get the right help. Don't take shortcuts with your health. It is your health, and it is your faith.
Definitely. Dr. Thuva, thank you so much for taking out your time and coming on to our show. We were absolutely delighted because you gave us another spin to the whole story and the aspect, because it's quite enlightening to hear these two aspects. And of course, it is important that we seek attention if we need to. For instance, if you've got hyperpigmentation, Dr. Thuva was under the thought that it is very important that you speak to your GP if you've got any concerns and sort of address them. Viewers, I hope that you enjoyed our show today, and hopefully we'll be coming again next week with another topic, and we're going to discuss that. And of course, if you want to be part of our show, it's very, very easy. We hope you have a lovely week. Take care of yourself. Allah Hafiz.